Thank you, Sydney, and we'll pass it over to Dr. McClain to share a little bit about his background and just get more into the details of LCH.
Sure. Thank you for the invitation. Appreciate the chance to speak with everybody. It's really nice to catch up with Sydney and Brad and Tracy and reconnect after many years. And they were a very important part of my life through the HAA and through research efforts. And so it's nice to see them. I'm a professor of pediatrics at Baylor College of Medicine, and I've been here since 1986. I work at Texas Children's Cancer and Hematology Center, which when I came here in '86, only had 5 physicians. Now we have over 100 practitioners, and we have the largest pediatric cancer center in the nation. And my connection with the histiocytosis world really started in my fellowship at the University of Minnesota in 1979 because my mentors there, Dr. Mark Nesbitt and Robert Henning, and some other physicians were interested in the histiocytic diseases. And one day I was on a rotation where I was doing bone marrows on adult patients, and a man who ultimately had what we call HLH was the patient I had to do marrow on. So I did it, his marrow. I came back and looked at the cells under the microscope, and there were all these macrophages eating cells around them. And it really struck my fancy. And I think that kind of what keyed me into the whole histiocytosis world. And although I was doing research in another field at that time, when I moved to Houston, I became more involved with histiocytic diseases and with patients because they were coming to our institution. And through the wonders of social media, more and more patients came to our institution. And in 2001, I started a histiocytosis center. And so that center helped bring the more and more patients to the point where we are seeing over 120 new patients with histiocytic diseases from around the world every year. And this has powered our translational research, which is really managed by Dr. Carl Allen, who joined me as a fellow in 2006 and who has led our research effort with really amazing collaborations from other physicians around the world. So what is Langerhans cell histiocytosis? I mean, I think it's kind of shrouded in mystery over the ages, and the name comes from a physician. Actually, he was a medical student, Paul Langerhans, who in Vienna in the 1800s was looking at the skin, and he stained the skin with a special thing that brought out the shape of cells. And he saw these cells with arms on them, kind of extending everywhere. And he wrote his paper in German that said something about the nerves of the skin. And fast forward to 1970, a pathologist in Paris, France, was doing research on the disease that we now know as Langerhans histiocytosis. And then it was called histiocytosis X because nobody understood it. And there were lots of different names. There were eosinophilic granuloma and letter Siwi and Hans-Schur-Christian disease. And they eventually kind of became understood as one thing. But anyway, he was doing research with his electron microscope, and he saw some interesting little granules, we'll call them, in the center of the cytoplasm of these cells. And these granules were also found in those cells that Paul Langerhans had seen in the skin. And so Christian Neselov said, aha, these are Langerhans cells. Until 2010, it was understood that the disease was caused by cells that originated in the skin, somehow became misdirected and then moved out to other places in the body and created the holes in the bone or the rashes or the pituitary involvement or other things which we know this disease can affect. And so it was called Langerhans histiocytosis for a great number of years. In 2010, Carl Allen in my lab did some really groundbreaking research in which he discovered that those cells that cause the disease really come from the bone marrow, and they're not the skin cells at all. So we now know this as a bone marrow-derived disease, and we call these cells dendritic cells because of the arms that are reaching out from them. And their purpose in life is to pick up information from the blood or the skin or your oral cavity and pass that information to lymphocytes. And that informs our immune system what to do about defending us against infections, cancer, and other dangers that might come into our body. And also in 2010, the very seminal research was done by the group at Harvard at Boston Children's, where they discovered the mutation called a BRAF or BRAF. And subsequently, we've proved many times over that somewhere between 57 and 65% of all LCH patients have this mutation, but the rest of them have some other mutation that's in a pathway that is a pathway of information in the cells that helps the cells know when they're supposed to grow, when they're supposed to stay someplace, when they're supposed to move. And those mutations have misdirected the cells. So they, instead of moving around like they're supposed to, they sit in one place. And that's why in the disease, Langerhans histiocytosis, they collect in a place like a bone and make a hole, or they collect in the skin and make a rash, or they collect, in other organs like liver, spleen, bone marrow, pituitary, brain, lungs, wherever they decide to go. So it's really been a very exciting time since 2010 because our previous misconceptions about the disease have been really redefined. And it used to be thought this was an immune disease because when you looked at biopsies, you saw a few of these histiocytes, and they were actually a minority of the cells in the biopsy, and all around them were lymphocytes and macrophages and neutrophils and red cells and platelets. And so people thought, well, this is an immune disease. It's kind of like inflammation, like a infection or some sort of immune dysregulation. But come to find out now, the reason that all those cells are collecting is that the LCH cells are sending out signals, and they're saying, hey, Mr. T cell, come over here. We got work to do. The problem is that they're doing bad things to the T cells, so the T cells are kind of paralyzed. I mean, they're there, but they're not working the way they're supposed to. And that's one of the fascinating things about this disease, that yes, it modifies the immune system, but at the end of the day, it's really dysregulated dendritic cells that are causing it. And so people have asked me, is this a cancer? And I think the simple answer is yes, because if you get this BRAF mutation in skin, you get melanoma. If you get it in your colon cells, you get colon cancer. If you get it in certain kind of lymphocytes, you get a type of leukemia. So yes, it's a malignancy, a new growth, but it really is a much less aggressive kind of cancer than many other things we think about, such as leukemias or some lymphomas, or of course, many adult cancers. So it's one of those diseases where the stepwise improvement in our knowledge over the years has been really fascinating. And there are some of the kind of preconceived notions about this disease. It was caused by an infection. And I guess about 30 years ago, I looked and looked and looked for viruses, and I never found any. And some people think that trauma causes the disease, but I think that's really just a coincidence that someone bumps their head and subsequently they get an LCH lesion where that bump was. And so these things happen in other diseases too. It really is part of a family of diseases, so that all the other diseases you're hearing about today, whether it's Erdheim-Chester, Rosai-Dorfman, juvenile xanthogrammioma, or even HLH, they all originate in the bone marrow from what we call myeloid cells. And they are a type of white blood cell which has a very primitive stem cell, a great-grandperson cell, and that cell can mature into what we see as Erdheim-Chester or LCH or Rosai-Dorfman, and just little tweaks in the way the cell develops and what some of the environment around it. And I don't think we have a very sophisticated idea about why they go those different directions, but they kind of are based upon what stage of the myeloid cells are affected by the mutation. And that has a lot to do with which disease you get, just where that mutation is. So Langerhans cell histiocytosis affects about 4 to 8 children per million in the population, and perhaps 1 in a million in adults. There's only one paper that really shows that convincingly. And the strange thing is that we call this a rare disease, but in fact, Langerhans histiocytosis has the same frequency as Hodgkin's disease in children. So everybody knows about Hodgkin's lymphoma, but they don't know about LCH. So I think it's a bit of the branding of the name and just familiarity. And It's one of those things that frustrates me that in medical school, that a lot of students don't hear about this and they kind of discover it when they're residents or even when they're in practice. And I wish we had a way to teach these things at an earlier stage, but that's always a problem with curriculums that they get set up in certain ways. Let's see, we talked about views. Oh, yeah, some of the misconceptions. One of the other misconceptions about the disease is that when LCH gets into the brain, it can make some changes in the back part of the brain called the cerebellum. And those changes are probably an inflammatory change because the LCH cells actually migrate into the brain from blood vessels. And those cells that are migrating are very, very immature cells, and they don't look like the normal LCH cells that you'd find in a skin biopsy or in a bone biopsy. So there's certain surface characteristics of these cells that we use to make the diagnosis. And there's a stain called CD1A and S100. And these cells in the brain don't have that. But if the patient has the BRAF mutation, you can find that BRAF protein in the cells, whether they're in the skin or the bone or the brain, and you can prove that these cells in the brain are the BRAF mutated cells that cause LCH. So the LCH effect on the brain can make these different pictures in the MRI, and the MRI is a very sensitive test, and it's based upon a molecular way that the magnetic field interacts with water molecules. And those interactions make the pictures that you see on an MRI picture. And when the waves of the magnet spin a different way, they make a different kind of grayness or whiteness in the picture. So this whiteness change in the back of the brain is what I like to call an LCH associated change in the brain. And the patient may be perfectly well. In other words, they don't have tremors of their hand, their speech is entirely normal, they walk and run and play perfectly normally. So if they have problems with those things I just mentioned, that is a sign that they could have neurodegeneration. But if they just have the MRI findings, then that's an association. So people get a little freaked out when, unfortunately, radiologists and pediatric oncologists say, well, you've got neurodegeneration in your brain. And that's really not an accurate definition. And so I hope to spread the word that just because you have a different look in your MRI doesn't mean you have neurodegeneration. In fact, we have really good medications now to treat that problem. But I'll get there in a minute. Try to follow my script here, Nate. So diagnostic challenges. Well, LCH is a great mimicker, and went back and when I was in medical school and we didn't know about LCH, but there were other diseases that were confounding us, and they used to call syphilis the great mimicker because it could do things that created problems like a lot of other diseases. And that's a story with LCH. So there are probably a dozen childhood rashes that look exactly like LCH. And it's no wonder that little babies with these rashes can go months without a diagnosis because the dermatologist tried this ointment and that ointment and phototherapy and a variety of things. The sores in the mouth could be a virus infection. The drainage from the ears could be just a bacterial infection. Holes in the bone could be from a congenital problem, an infection, another kind of tumor, or LCH. And of course, lung disease. There are other lung diseases that cause what we call interstitial changes, which means fine little scar-like things on the internal part of the lung. And so there are diseases that cause big liver and spleen, like leukemia and lymphoma. So there's lots of overlap with other diseases. So how do you find the diagnosis? Well, you do a biopsy. And most of the time, the pathologist can make a pretty definitive diagnosis and tell us it's LCH, as opposed to Erdheim-Chester, which doesn't. We don't have that grace. We have to use our clinical judgment. But anyway, LCH is pretty readily diagnosed with a biopsy, and nowadays we test for the BRAF gene as well as other genes of this pathway that control the growth of these cells, because the information from those genetic tests inform us about what drugs can be useful and what are good choices and what aren't such good choices for these patients. So what is the standard of care? Well, a few years ago, I might just say vinblastine and prednisone, because those are the two drugs we've been using for 50 years. But the truth is that vinblastine and prednisone are really not very good treatments because 50% of patients fail that treatment. And nowadays we have the inhibitor drugs, we have clofarabine, we have thalidomide, we have other drugs that affect the immune system. So I think the standard of care is evolving, and I wouldn't want to say that there's one standard of care. I mean, a lot of the care that's given in various places throughout the country is dictated by the experience of the physicians at that place. And there are some institutions where they start with the inhibitor drugs, which will stop the activity of the BRAF mutation or the MAP kinase mutation. And those drugs are very successful. They really work quickly and effectively. The problem is that when you stop the drugs, the patients have a very, very, very high chance of relapse. And so we're still trying to decide, is there a group of patients who would effectively benefit from these drugs and be cured or not? And I think that question is still open. In our institution, we do use the inhibitors. There are patients who definitely need them. The patients with a high-risk disease who are extraordinarily sick can be made so much better within a few weeks, as opposed to in the past when we gave them vinblastine prednisone or cytarabine. It took a lot of time before they were better, and they suffered a lot of complications from infections and such. So we now use a drug called clofarabine, which is by far the best chemotherapy drug we've ever had for this disease. And it is very effective in killing the clone. So if you have a patient who you get better with an inhibitor alone, but they still have these circulating cells that have the BRAF mutation, then we use the clofarabine drug to get rid of that clone and then ultimately cure them of their disease. So that's kind of the leading edge of where we are, and we're still discussing how we're going to kind of mix and match these kinds of drugs in the armamentarium that we have for various patients. So like a lot of diseases, there are disparities in care, and it's really tragic that our medical system does not have universal coverage, and that people in rural areas or people in economically disadvantaged places in our cities don't have access to care. And so I think it's incumbent upon us as physicians and for the HAA and all kinds of family groups to advocate for patients with rare diseases and to help spread the word that we have to give equal care to everybody and provide them with the opportunity for a safe and good life, like Sydney. And it's really wonderful to see her and hear how she's excelled in so many ways in her life. One of the problems in this field of LCH is that adult patients suffer even more than children, and I call them the orphans of this orphan disease. And that's because, unfortunately, internal medicine doctors have not paid attention to this disease, and because of the overlapping signs and symptoms, they don't think about it for a long time. And unfortunately, the way internal medicine is practiced, there are so many specialists that if a person with a lung disease goes to a pulmonologist, well, the pulmonologist takes care of that, and they might do the tests and figure out that the patient has pulmonary LCH, but they don't think about the other organ systems, the skin, the pituitary, the bones, the mouth, the ears, it's like on and on. And unfortunately, over the course of my career, I've heard way too many awful stories of patients who have suffered for way too long because their full disease was not understood. So I think that's one of the challenges that I keep struggling with, and Eli Diamond and Gaurav Goyal and others in our society are asked to speak at the American Society of Hematology, which has 30,000 members at its meetings. Most of them are internal medicine doctors. And so we try to get the word out and spread it, incrementally in the world. And thankfully, there's a organization that's called the Community Cancer Center, National Community Cancer Center organization. And they have put out a how to do it manual for lots of cancers, including LCH and Erdheim-Chester. So I think that's a huge step forward to help the local oncologists who might not have had any patients with this disease or nor very little understanding. So I think incrementally we're getting a little bit better, but it's still kind of frustrating to hear the stories of patients who have been neglected. And as far as the differences between children and adults, I see adult patients and children, and the biggest challenge I have is trying to find a way to deal with the adult patients who have so much trouble with chronic pain and fatigue. And some children have that problem, but it's nowhere near the highest frequency as adult patients. And so we don't really have a good answer for that yet. And that's one of the things that Dr. Goyle, Diamond, and I are working on to form a sort of a joint task force to look at the symptoms of patients and to evaluate the patient's story by the patients telling us more about what happened to them, just like Sydney just shared. And these efforts are called patient related or reported outcome rather. And there's a big initiative going forward to do this for the patients in the histiocytosis world. So I'm hopeful that'll give us more clarity about the frequency of these problems, and hopefully we can get young physicians who are very smart about pain management and fatigue management to provide us some new interventions. So I think the HAA forms a very important role here in this world of advocacy because they're doing a tremendous job of getting the word out to families, and like what you're doing here today, Nate, and your organization to put things on the web that are easily available, to advocate for our politicians to support the research and funding of treatment of rare diseases, and to provide funding for research, which is, of course, critical. And without the research, we'd still be kind of in the dark ages here. And thankfully, we've acquired a lot of good allies in the world of stem cell biology and myeloid and dendritic cell biology. I mean, our own research was propelled tremendously by our collaboration with Miriam Murad at Mount Sinai Hospital in New York, as well as researchers in Europe. So it's all about collaboration, and nobody can do it themselves, and it's really what makes us feel very exciting. So I'm kind of winding up here, Nate. Is there something else you want me to cover, or should we open it up for questions?